Thank you guys so much. I see lots of participants that are joining our webinar. Thank you so much for participating on this very cold and snowy Friday in February. We have an awesome speaker for you today. We all know that EMS are very, very important to the care that we provide to our patients, and especially those patients that are suffering from cardiac emergencies, because we know that time is muscle and it's essential that we get people to help as soon as we possibly can. So we have a wonderful speaker in Dr. Bart Francis, who's going to talk to us about the importance of EMS systems in cardiac care. And before we get started, let me let you know that our Q&A is going to be open throughout the webinar. I will keep a watch on that, and I will let Dr. Francis know of any questions that you may have at the end of our webinar. So please feel confident in asking your questions. And if you can't get through on Q&A for some reason, then you can email me those at dharmon@arh.org, and I will have them in front of me by the end of the presentation. So Dr. Francis, I'm going to give you the reins if you don't mind to quickly introduce yourself and then just take it away.
Thank you for having me available for this presentation. So today we wanted to talk about EMS and the importance of EMS systems in cardiac care. I work with Appalachian Regional Healthcare as the director of the emergency departments for all 13 ARH hospitals. And I work as the regional medical officer with SCP Health, which is the agent or the company that ARH uses to staff the ARH ERs. And I've been with ARH a little bit over 20 years. So I serve ARH also as a member of the Board of Trustees, and I'm the EMS medical director for a number of counties in Eastern Kentucky. So, and I'm looking at the names on the right here, and I recognize a lot of names. So I appreciate everybody calling in, and I guess we'll get started. Danielle, if you could advance the slide. All right. So one of the things that to recognize as national EMS systems and EMS education systems, until about the early 1970s, a lot of EMS systems throughout the country were local. Interestingly, funeral homes served as ambulances in a lot of rural communities up until even the 1980s and sometimes in the late 1980s. So in 1973, the National EMS Education System was developed. And at that point, there was a unified data reporting system available. And so it really served to gather a lot of information. It served to give a lot of positive information in terms of systemization of EMS agencies, so that we're able to gather information and then proceed with evidence-based approach. So it really showed the benefit of an organized EMS system. And then next slide. EMS calls during COVID. Now, we all know that things were rolling pretty good, very systematic up until COVID. COVID really threw a wrench in EMS. So EMS calls declined about 26% nationwide at the beginning of the COVID pandemic. The calls for chest pain was down about 42%, strokes down about 36%. And the ED volumes across the United States declined about 25%. So a fourth of the people that were going to the ER in January of last year stopped going to the ER in March or through and up through now. Volumes have continued to be lower, and the acuity in the ERs, according to national organizations, actually increased, but the actual volume certainly declined. There's been more of a push and need for ICU beds, and that's been certainly in shortage throughout the country. And in our region, we've seen that. We see ER overcrowding. That has become more acute than it was a year ago because of staffing shortages at hospitals. And it's not unique to Appalachia or to our region. The staffing shortages are nationwide. And so ER overcrowding, and SCP Health has about 430 or 40 hospitals throughout the country. So I interact with a lot of medical directors and our leadership from around the country. The ERs around the country are overcrowded. And so COVID has really contributed to that. And then when EMS calls mirrored the decline in ER volumes, it certainly put more financial stressors on the systems. And the one thing that you worry about is if your calls for chest pain is down, your calls for stroke are down, people are still sick. People are still having acute illness. People were afraid to seek care. And that really negatively impacted us for a long time. So next slide. So talking about heart attack calls, myocardial infarction in EMS, only about half of heart attack patients get to the hospital by ambulance. Now, that's counterintuitive thinking for a lot of us, because you think if you're having a heart attack, you're certainly at you're having severe chest pain. You're not able to maybe function as you normally would. But half of our heart attack patients get to the hospital by private car. But the patients that get there by EMS, they have a lot faster receipt, and they have a lot faster initiation of reperfusion therapy. So the EMS patients get better care, have better outcomes, and faster access to myocardial reperfusion for particularly the STEMI patients than the patients that come by car. So there's an opportunity for EMS to educate and offer the general public a lot of education, in that if you're having a heart attack, or if you're having heart attack symptoms, if you come by ambulance, you are more likely to get more rapid care, and you're more likely to have a better outcome. So that's certainly a takeaway point from this, is that educating the community about utilizing the EMS system for heart attacks does provide an opportunity for improvement. Next slide. So MI treatment, how do you treat a heart attack? You reperfuse. Now, the most important thing that you have to remember about a heart attack is all the things that we do can promote a long-term downstream positive effect. But reperfusion is the mainstay of treatment for a heart attack. So if somebody has a blocked artery, you need to get that blocked artery open. So in the back of your mind, when you get a chest pain call, the first thing you need to think about is heading toward a PCI capable facility. So PCI capable facility is certainly one that has the ability to do a cardiac catheterization, get a wire across the blocked artery, balloon it open or stent it open, so that there's immediate reperfusion. And there's standards in place for the door to balloon times. There's standards in place for initial EMS call to balloon times. And so the quicker you head toward a facility with reperfusion capability, the better. You know, in Kentucky, the EMS systems talk about the closest appropriate facility. And in truth, if you have a patient that has a STEMI, your closest appropriate facility is a facility that can provide that reperfusion therapy. Next slide. So the benefits of reperfusion: you save myocardium. So time is heart muscle, and that's a true statement, and it's something that's thrown around a lot. But time does matter in terms of salvaging myocardium. It decreases mortality, less likely to die from a malignant cardiac arrhythmia if you get quick reperfusion therapy. Decrease in morbidity. So, you know, there's a lot of patients in over the years that survive a heart attack, but they go from having a normal cardiac ejection fraction, their heart's pumping well, they're able to do their activities of daily living, they're able to go shovel their snow or whatever's going on today. But then they have a heart attack and they don't get rapid reperfusion, and then what happens? They may live and they may lead a fairly normal life, but you get low exercise tolerance. And you know, you would hear the term cardiac cripple, but it really means that the cardiac function deteriorates to the point that they're not able to do their activities of daily living. They're not able to climb up and down a set of steps. They can't function in their own house. They can't even walk across the room sometimes for getting out of breath. So if you can get a quick time to reperfusion, then you improve the functional status and you have a much more likelihood of return to normal activities. And really, time matters. 3 to 6 hours is kind of that golden window for reperfusion therapy in a patient with a heart attack. And next slide. And methods of reperfusion. Preferable method is PTCA. In other words, putting a wire across the clogged artery and opening the artery. The other option, and this is utilized still in critical access hospitals and in rural communities without access to the PTCA treatments, the stenting, the thrombolysis, TPA, TNKase. Those are still used, and we review with our physicians that if you can't have rapid access to a facility that has the capability to stent a lesion, then they should give the reperfusion drug therapy in an attempt to open up the blocked vessel. It's not it's not preferable, but sometimes it's necessary. And recognizing that, for example, like a couple of nights ago, if you'd been at one of our critical access hospitals that doesn't have reperfusion, percutaneous reperfusion capability, a cath lab, with the weather as bad as it was, not very likely you're going to get somebody out in a timely fashion. And sometimes you just have to use drug therapy to reperfuse patients. And then the other thing is a cabbage or a heart bypass. So if you can't traverse a wire across the blocked artery and open it up, then sometimes you have to proceed to a bypass surgery, and that can be a single vessel or sometimes triple vessel, 2 vessels, to bypass the blocked artery because you just can't get it open any other way. So next slide. So ways to improve outcomes when patients choose to utilize the EMS system. Number one, avoid transport delays. So we should be able to get people to a definitive point of care as quickly as possible. Now, your 12-lead EKG should make a difference in your destination. If you have the capability to transmit it to the ER, that's great. If you don't, then that's okay too, because you can communicate with the receiving facility by telephone or radio and do a cath lab activation in patients that have a STEMI. All of our ARH PCI hospitals have the availability for EMS to activate the cath lab through the ER. And don't be afraid of a false activation. It does happen. It's better to have a false activation than no activation if you have a patient with a STEMI. And sometimes that can just be accomplished by conversation with the ER doctor at the receiving facility. And I know that there's some folks on the call here that have called me and said, hey, I'm inbound with a STEMI coming from, over in Leslie County. And I'll activate the cath lab, and we'll have the cardiologist ready and standing by or en route if it's after hours. So in the meantime, your proper destination is important. If you have a patient with a STEMI, you can really help that patient by going to a facility with PCI capability. It avoids a delay in reperfusion. It gets the patient to a definitive point of care more quickly, and you have a lot higher likelihood of the patient having a good outcome rather than delaying care and having to facilitate transport to another facility. So this is just heart attacks are one of those EMS activations that it's important to go to the right facility in the lowest amount of time. In the meantime, follow the protocols: aspirin, beta blockers, nitrates, morphine, whatever you need to do to transport the patient. But ultimately, getting that artery open is of paramount importance. And Danielle, next slide, please. And talking a little bit about the future of EMS field therapy. There have been studies, and when Danielle asked me to do this talk, I actually read quite a bit about some things that are going on in Europe. And there have been some trial programs in the US, even in Texas, and we've seen some of the trial programs in which they put CT scans in ambulances as well. There's trial programs for pre-hospital thrombolytics, and it's been shown in Scotland and in Europe that this can be beneficial. In Scotland, they did an interesting study in which general practitioners in their offices would have a bottle of TPA. So if somebody goes to their doctor's office in Scotland and they had heart attack, had an actual ST elevation MI, they would pop an IV and simply just give them an aspirin and a TPA, and en route to the hospital, and outcomes improve. And in Europe, they've done some of the same things. So although it's not widespread, and as you know, we all hate change, and adoption of new things is slow in medicine and EMS. because we all want to try and test it and show that, that we have benefit. But look toward the future in terms of the possibility that in the field, we may be administering thrombolytics for STEMIs that are recognized in the field with long transport time. So I think that's something that may be exciting in time to come. And in kind of that same vein, talking about reperfusion checklists, indications, the absolute relative contraindications of early reperfusion therapy. So right now, if you can communicate to the destination ER, hopefully it's a PCI facility, that you've done a checklist with the patient, that they haven't had any recent surgery in a non-compressible site, that they are not that they haven't had any blood in their bowel movements, or that they're not having any blood in their urine, or they haven't had a recent brain surgery. If you can go through a checklist with the patient on the way to the hospital, it can really help speed things up when the patient gets to the hospital, because you've already got a checklist. And I think if you look in the protocols, there are already some checklists in there. You should have a destination plan when you pick the patient up. That destination plan, as soon as you get that EKG, if there's a STEMI, your destination plan should be to a facility with PCI capability, and there should be a quality assessment or quality improvement program. And then, in terms of the administration of TPA in the field, or TNKase in the field, there's going to have to be community support around that. And what I mean by community support is the medical community is going to have to support that. But I do think that may be something that we start to see in the future. Next slide. All right. So everything that EMS does out in the community, particularly during COVID, has been a challenging time. People have put their lives at risk to take care of patients. And, certainly from the folks at ARH, from myself and from our ER teams, it's appreciated. Sometimes I know it feels like you're not appreciated when we're getting 4 or 5 patients at one time, but ultimately what we're doing does matter. And in kind of shifting now to ARH, ARH is, we operate 13 hospitals throughout Appalachia. 3 of those hospitals are primary PCI facilities. So if you bring a heart attack patient, a STEMI patient, to Hazard ARH, Highlands ARH, or Beckley ARH, there are programs in place. There's primary intervention program in place in which there's dedicated cath lab, there's dedicated interventional cardiologist 24 hours a day, 7 days a week. And there's a process in place to get that patient door to the cath lab, get that artery open in the quickest time possible. So that being said, if you're in one of our ARH communities and you have patients that are a candidate for thrombolytic or for a PCI, sorry, if you have a patient that's a candidate for PCI, in other words, they're having a STEMI, your destination choice really should be one of those 3 hospitals. There's other hospitals in the region, depending on what your service area is, and you should be familiar with that have PCI capability. And it really doesn't matter it doesn't matter if it's an ARH or a non-ARH. You want the patient to have the best outcome. So you should go to the closest hospital with PCI capability. You should never, ever bypass a hospital that has PCI capability for a patient with a STEMI. Patients will have better outcomes if you can get them to those hospitals with PCI capabilities quickly and efficiently. So that's the end of what I had to say. And then I think Danielle was just going to open things up for comments for a few minutes.
Absolutely. So we do have a couple questions that have come through on chat. And then one more question that I have for you. So I know we have at least 3. The very first one I think I can answer, and that is, does Hazard ARH have 24/7 cardiothoracic surgeon coverage? And we do. So that's very good for everyone here to understand and to know. The next one is, you talked about how they should not be fearful about activating our cardiac cath labs, and how sometimes there may be some difficulties in communication between EMS and between our ERs. Can you talk a little bit about what those difficulties may be and how we can overcome them?
Well, I think that, and I'm reading the question, talking about patients coming by POV, delay in response time, EMS, and they can be to the local ER before they arrive in their home. And that may be true, but unfortunately, patients don't know often the capability of their local ER. So EMS does know the capabilities of the local emergency departments, and keeping in mind that the EMS destination should be the appropriate facility. If that's a PCI facility, then there can be an improvement in outcome by utilizing EMS, rather than going to the closest hospital. I mean, and we all know that if you, and this, we learned a lot of things in trauma care, over the years. If you have a true multi-trauma patient and you go to, if you go to the hospital, the critical access hospital that has no surgeon, and the patient has major multi-trauma, you have to facilitate a transfer then to a trauma center. People have better outcomes if you go directly to the trauma center, or if you go to a center with surgical capability. You can really improve the access to care, by taking patients to the right place, from the get-go as far as the destination goes. So all the EMS agencies should be directing to the closest appropriate facility. And for a STEMI patient, that facility is a PCI facility. And I tell all the counties for which I'm a medical director, go to the closest appropriate facility that has PCI capability. And I hope that throughout the region, the medical directors and the EMS agencies are working together to make sure the patient is going to the right facility all the time.
Thank you. Thank you. That was someone posted that sadly, a lot of our EMS don't make the decision to take them straight to a PCI instead of, or they just take them to the local ER the hospital may not have PCI services. So it's very, very important. And I know it's overstated, and we talk about it all the time, how time is muscle, but that's especially true. If you have somebody that has a STEMI, to get them where they can get the most appropriate care. And sometimes it's very, very important for our EMS to be educated about where those PCI services are. So can you reiterate where those are for ARH?
Well, for ARH, PCI services at Hazard, Highlands, and Beckley. So, and that's something that that's been a point of education every time I talk to our EMS services, for which I'm the director. Every time I talk about destination choices, and there's a lot of different reasons for different destinations, but this is a special case. If you have a patient with a STEMI, you should get that patient to a facility with PCI capability. This is the kind of situation in which any old ER is probably not the right answer. The appropriate ER is the right answer. So you need to get them where that the patient can be taken care of in a PCI facility. It can really make a big difference, long-term difference.
Mm-hmm. Thank you. Thank you so much. I think that is all the questions that we have. And if you have posted a different statement or anything else, then Dr. Francis can see those on our Q&A, and please be aware that we are listening to you. One of them is that we need some additional education to EMS. And so that is certainly something that we will take to heart, and we will try to implement as even more than what we already do now. It's very important for our EMS, our relationships to be maintained, but also to learn, should we have any more PCI programs pop up, we will let you know, and then to continue our education on what we do have in our availabilities. Mm-hmm. So, Dr. Francis, I think that is all that we have today. Thank you so much for presenting for us. And then, again, if you guys have any questions, please email me to dharmon@arh.org, and I will get with Dr. Francis myself and get you your answers. If you have not asked them today, or if it's something that you don't feel comfortable adding into the chat, please let me know, and we will get you your answers. So thank you so much. Again, thank you, Dr. Francis, for being here. Hopefully we can have you back on again in our webinar series, and then even more broadly out to the community about your ER work with us. So thank you so much.
Well, I appreciate you, and thanks to everybody that joined, and do appreciate everything that EMS does. It's been a hard year, but it's looking up. I think that the COVID cases are declining, and if we can get past this weather, I think we're going to have a really good summer.
Oh, my fingers are crossed, and I'm so hopeful. I really hope so. Let me check our chat box one more time, see what we have here. Thank you, Dr. Francis, we appreciate you. So, and then ARH appreciates our EMS providers, not just during February Heart Month, but every day. So, and that is very, very true, could not be more true. Thank you so much, EMS, for all that you do. And please feel free in contacting us, reaching out. Like I said, we want to maintain those partnerships, and we are very, very appreciative for you. So with that, we will end our webinar for today. So thank you again, Dr. Francis. Thank you, our participants. Please stay warm and safe out there. And if you had not had your vaccine yet, go get vaccinated. So thank you guys so much. Have a great day.
Thank you.
Thank you.
Bye-bye.